Hello. So today we are going to talk about acute renal disorders with acute kidney injury that leads into chronic kidney failure. So first, let's talk about acute kidney injury. When we start talking about that, let's talk about the functions of the kidneys. So what does the kidneys do? The kidneys perform several essential functions to help maintain the body's overall health and homeostasis. It filters the blood. Remember, it filters waste products, toxins, excess substances like water and salts and acids that we don't need, and from the blood to form urine, which is then excreted. It is our fluid and electrolyte balance. It's the system that helps regulate the water and the electrolytes, such as sodium, potassium, and calcium, to keep everything in a healthy range. It helps with blood pressure regulation by adjusting that fluid balance and releasing hormones such as renin. The kidneys also help control that blood pressure. It is part of our acid base balance that we learned. They maintain the blood's pH by excreting hydrogen ions and reabsorbing bicarbonate, and they help keep that body's pH scale stable. It helps with erythropoiesis stimulation, as the kidneys release erythropoietin, which is a hormone that stimulates the production of red blood cells in the bone marrow, and it also helps with the low oxygen levels. And it is a vitamin D activator. So it converts vitamin D into its active form calcitrol, which is essential for calcium absorption and bone health. So we see that the kidney has many functions, and it's very crucial to keep our kidneys healthy to maintain that body's internal environment in a stable system. And it helps ensure overall health within the body. So when we're looking at acute kidney injuries, there is roughly 2,000 to 3,000 cases annually. And what are we talking about when we say acute injury? It is defined as a sudden decrease in kidney function, which leads to an inability to filter the waste, balance those fluids and electrolytes effectively. And why does this matter? Well, with acute kidney injury, it will lead to serious complications, including fluid overload, electrolyte imbalances, and can even progress to chronic kidney disease if it is not managed promptly. So, what happens is there's a decreased blood flow or damage to the kidney tissues that reduces filtration. It leads to accumulation of toxins. It imbalances those electrolytes, and that causes a fluid overload. Aging population are in increased risk for acute kidney injuries, as the older adults are more vulnerable because of a decline in the number of nephrons within the kidney during aging process. Other risk factors include diabetics, people with heart disease, hypertension, liver disease, or the use of nephrotoxic drugs. People that have had major surgeries or traumas can be prone to acute kidney injury. So when we talk about the pathophysiology, again, it is a rapid and progressive form of azotemia. Now, when we talk about azotemia, that means an excess of nitrogen and urea built up in the blood. So nitrogen and urea is part of the waste products that the kidneys are filtering. And that is where we get our labs that we look at for the kidneys, the BUN, blood, urea, nitrogen. Um, so some of the early signs that we're going to see with azotemia is a decrease in urine output. We might have fluid retention, which would show up as swelling, edema, and possibly confusion. If azotemia or the acute kidney injury is not recognized and promptly treated, you're going to have advanced signs such as fatigue, nausea, shortness of breath, chest pains, and possibly even arrhythmias due to those electrolyte imbalances. With acute kidney injury, we look at the different causes of that. So we have pre-renal causes, intrarenal causes, and external renal and post-renal causes. Um, Pre-renal causes includes external factors that reduce the renal blood flow. So think about things that are before the kidneys. And it is the most common cause of acute injury. And these are a result of external factors again Nothing that's an internal anatomical structure, but things that are happening to reduce the renal blood flow and lead to a decrease in the glomerular perfusion rate. Decrease in renal perfusion affects that clearance of those waste products and therefore will reduce your kidney function. So, what are some things that could cause a pre-renal kidney injury? Think about things that cause hypovolemia, so dehydration. Maybe you have a severe case of gastritis, heart failure, myocardial infarction, sepsis, trauma, burns, possibly major surgery, and other things that can cause hypovolemia. So anything that affects the renal blood flow and perfusion causes a decrease in intravascular volume, vasodilation, which then in turn causes a decreased cardiac output and a decrease in your systemic vascular resistance, which will lead to hypotension. It takes about 20% of your cardiac output for an adequate perfusion to the kidneys. But again, this can be reversed by fixing the cause. So it's a prompt assessment and treatment to help make sure that we are resolving this as soon as possible. Intrarenal damage in the kidneys involves the direct damage to the renal peritoneal tissues, which result in an impaired nephron functioning. The nephron is the internal functional unit of the kidneys, and a direct assault to this nephron will cause a decrease in the perfusion and the filtration of the waste products. Things that cause problems with the internal intrarenal structure could be from inflammation, infection, hyper or hypotension, or vasculitis. So think of things like glomerular nephritis, acute tubular necrosis, nephrotoxic drugs such as NSAIDs in contrast. And one of the main causes is acute tubular necrosis, which due to the lack of perfusion, we get ischemia, which causes the decrease of per, perfusion and filtration, and nephrotoxic drugs, being exposed to substances repeatedly, such as IV contrast and certain types of medication. Post-renal obstruction occurs after the kidney. So this involves a mechanical obstruction of the lower urinary tract. Think about your ureters, bladder, urethra. So as the urine leaves the kidneys, the flow is obstructed at some point through the ureters, causing a reflux into the renal pelvis and impairing that kidney function. So a post-renal obstruction would be something such as a kidney stone, possible tumors, or even benign prostatic hypertension, which causes the inflamed prostate, which will then decrease your outflow. So those are the causes that we look at of acute kidney injury. So now let's look at the phases of your acute kidney injury. So again, acute kidney injury is classified into these three stages based on your serum creatinine levels and the urine output. So the beginning is the initiation phase. It is the onset of injury, lasts typically about 5 days, and it ends when you actually have an injury to that kidney. So again, initiation means it begins with the cause of the event and ends when we notice that tubular injury. So maybe that increased serum creatinine level. The oliguric phase lasts up to 14 days, possibly longer, but this is when we're going to see a fall in our GFR and notice that tubular necrosis. We're going to have oliguria, so meaning the urine output will fall below 400 mLs per day. We'll notice that azotemia, which again is an excess in the urea and the nitrogen in the blood. We notice fluid retention due to that decreased GFR. And this is where we're going to see a lot of our electrolyte imbalances: increased potassium, increased phosphate, increased sodium, and a decrease of calcium. And again, remember, when we have an increase of potassium, we need to treat that as soon as possible with Kayexalate to help and also monitor for cardiac disturbances. And we also, during this phase, might notice a metabolic acidosis, Remember, our kidneys help us balance that pH, and when it's not in balance, we could shift the other way. The next phase is the diuretic phase. This will last from 1 to 3 weeks, and this is where your acute kidney injury is starting to be corrected. We start getting osmotic diuresis that will result in a high urea level, so we have an increase of urine output, and this can be anywhere from 1 to 3 liters up to 5 liters per day. But because of this massive diuresis that the body is starting to do, we have to be cautious because it can lead to dehydration, which will cause an electrolyte imbalance as well. And this phase ends whenever those BUN and creatinine levels begin to normalize and we start noticing a balance of the electrolytes and the acid base ABGs are balancing out. And our last phase is the recovery phase. So this can last for several months up to as long as a year. And this is where the body is healing itself. So you have tubular cell repair, an increase of your GFR, your urine is going to return to a normal output. And again, throughout this whole time, we're going to monitor those lab values and help the patient to have preventative measures for it to return. So let's talk about some of the nursing management. So when we're doing the assessment and analysis, we always need to make sure that we're looking at clinical manifestations that are related to that GFR that's being decreased, that are related to the fluid overload and impaired clearance of those electrolytes. So we're looking at some of the nursing assessments. With our vital signs, we're going to watch for hypotension. Remember, they're not putting out that urine. We're going to look at tachycardia, which may be present initially and reflects that hypovolemic state that causes the acute kidney injury. Later on, we might notice more of a hypertension because of that fluid overload. We're going to monitor the urine output. The urine output is decreased initially because of decreased circulating volume, but later it will be more decreased because of the impaired clearance. Once we see an increase of the urine return, that means that it is starting to get better. But during this time, we may even notice protein and blood in the urine with a high specific gravity. With our laboratory values, we're going to notice an increase in BUN and creatinine because of that reduced clearance, an increase of potassium due to the reduced kidney clearance, a decrease in sodium because the kidney is unable to conserve it. Our hemoglobin and hematocrit could be decreased due to the kidney's decreased production of that erythropoietin. Remember, our calcium and our phosphorus bind together. So the calcium will decrease due to it binding to the phosphorus, and then your phosphorus will be higher. But due to this is where we start having issues with brittle bones. And we're also going to look at our arterial blood gases. Remember, these patients can easily go into metabolic acidosis due to that inadequate clearance of acid, and we have an increased loss of bicarbonate. So we want to monitor those as well. We want to weigh the patient daily. Remember, an increase of weight may reflect the fluid overload. The weight is used to make a plan to know, do we need to get this patient on dialysis? We're going to monitor their oxygen and breath sounds. Remember, we're looking for fluid overload, so we want to monitor that to make sure they don't have those signs of pulmonary edema. Peripheral vascular system, again, looking at that system of fluid overload. Do they have ascites, peripheral edema, distended jugular veins? And then we're going to look at some imaging, the ultrasound, a CAT scan, an MRI, just to assess that kidney size to see if there's any obstructions or abnormalities that could be causing our kidney injury. We're looking at medical management next. So let's talk about how do we eliminate the cause, prevent complications, help assist in that recovery, what medications are we going to give in, and possibly treatment with dialysis. So remember, our immediate goals is to restore that fluid balance and address the underlying cause to help prevent further complications. So we want to do fluid management. Remember, at first, if it's caused from a hypovolume, we want to give rehydration. We want to possibly have a restriction on fluids or possibly use diuretics. It just depends on what's causing that acute kidney injury. We want to make sure that we're watching our I's and O's. If we need to eliminate fluid and we're using loop diuretics, we definitely want to monitor those potassium levels and either um, help excrete the potassium or replace if needed. So again, we're looking at that electrolyte management. With our medications, we want to talk to our patients about stopping any type of nephrotoxic drugs and monitor that as well with their blood pressures. With dietary management, the goal is to prevent catabolism and give adequate carbohydrates, proteins, and fats, which is a necessary component of the diet. Potassium and sodium are usually strictly regulated. Sodium is restricted to help prevent that edema, hypertension, and heart failure. And potassium is generally restricted to avoid the cardiac complications that come along with the hyperkalemia. So remember, a low sodium and a low potassium. We want to try to limit that protein as the body has a hard time breaking that protein down. And, and that's why our nitrogen is high due to that waste product. And again, a fluid restriction may be necessary. And at last, dialysis might need to be considered in the short term to allow for recovery of the renal tissue while preventing possible life-threatening disorders. So with the nursing diagnosis, let's think about a few of these. Excess fluid volume related to renal failure and the renal retention. Fatigue related to that anemia, metabolic acidosis, and the buildup of uremic toxins. Some of the potential complications, we could have dysrhythmias arising from those electrolyte imbalances. Metabolic acidosis related to the inability to excrete that hydrogen, impaired bicarb reabsorption, and with decreased synthesis of pneumonia. So this is where our patients will have a little bit more of those symptoms such as anorexia and nausea and vomiting. Some of our nursing interventions with actions, we want to manage that fluid balance. Initially, again, we want to be cautious of what's causing the kidney injury. Do we need to give fluids or do we need to try to get those fluids off? We want to administer the diuretics as needed to help prevent the fluid overload. We possibly might need to administer potassium and we might need to get rid of the potassium. We want to make sure that our patient is ambulating as tolerated, that they're tolerating work of breathing, that they're not having any complications of immobility such as atelectasis or pneumonia. With their skin care, again, if they are in a hypervolemic or edema state, they can have decreased tissue perfusion and risk skin breakdown. And we want to monitor again that food intake and make sure that they are taking the right amount of nutrients that they need. Again, it all breaks down to what has caused the kidney injury and how are we going to fix that kidney injury.